morning, everyone. Welcome to Pediatric Grand Rounds. We are back in person in the lovely Mill Mountain Conference Room in Tanglewood. So if you're anywhere nearby, please come down and join us. Today's speaker is Dr. Jill Price, one of our third-year residents. Dr. Price is a graduate of the West Virginia School of Osteopathic Medicine. She has been an outstanding resident, and many of you may remember she did her QI project on trying to educate us on food allergies and introduction of foods in the young. After graduation, she will be moving back to her hometown and joining a UNC-affiliated practice in Lenore, North Carolina. Please join me in welcoming Dr. Price.
Thank you, Dr. Parmeshwar. Okay, so when animals attack, so today we're gonna, for Grand Rounds, we're gonna hit some overview of some zoonotic infections. Dr. Washofsky has been my faculty mentor for this. So no disclosures to report at this time. And here are some learning objectives. So kind of define some terms that we may not be familiar with, recognize the common presentations of some zoonoses, and then be able to kind of give the treatment for multiple zoonoses, and then acknowledge the challenges of identifying these and kind of overview of the resources that are available when one of these are suspected. So just some definitions to kind of get us started out here. So zoonosis, or plural zoonoses, are infectious diseases that are transmitted between species from animals to humans or vice versa. So it's kind of an overlying term that kind of encompasses multiple things. So if you are more specific, the anthroponoses are reverse zoonosis. So this is when humans actually infect animals. So it kind of is the reverse of what you would usually think about with these infections. And then sapronoses, this is when a human disease is transmissible from an abiotic environment. So these are when different kind of diseases can grow and replicate in environments such as soil or water. So in environments where they're not usually found and where they don't usually proliferate. Some examples of these. So anthroponosis, so when animals can infect humans. So a good example of that is tuberculosis. And then the sapronoses is when they can kind of grow in these abiotic environments. And so examples of those, histoplasmosis can grow in the soil, and then primary amoebic protozoans can, and then Legionella is an example of bacteria that can grow. So just an overview, so zoonotic diseases. So it's thought to be that greater than 60% of all human pathogens have a zoonotic origin, and then about 75% of new or emerging infectious diseases in humans come from animals. So we come into contact with animals in every single day, whether that is your pet at home, some people are farmers, and veterinarians, when we travel for sport, and then educational purposes, and including these are also insects and bugs. So every single day you're coming into contact with these and have the potential to kind of be in contact with these pathogens as well. So zoonotic diseases are found in bacteria, viruses, the fungi, protozoa, and parasites. And so we're going to kind of hit on a couple of the ones that we commonly see or commonly think about, at least, in pediatric patients. So individually, these are not very common diagnoses, and these are more of the zebra board question kind of things. But as a whole, together, when you put them all together, they're not uncommon, we'll say. And if you've been on the floor anytime recently in the past year, we've had some very interesting cases and some very confusing cases where we have kept our infectious disease partners very busy. And so a lot of these diseases we have at least had on our differential and have thought about and have tested for. And so it's important to think about these diseases, even if they don't actually end up being the definitive diagnosis. The importance with these is that these can all kind of have very vague symptomology, but it is very important that we do come up with the diagnoses, because these can range from, very mild asymptomatic illnesses to death. And so just thinking about it is good. There are people out there, CDC and WHO organization, that they have people that work on zoonotic infections 24/7 and trying to keep these things under control, kind of work on emerging infections and then keeping infections from re-emerging if they're kind of not around as frequently. So they prevent, detect, and then respond to any kind of outbreaks that happen. And so I thought that this was a pretty good topic that we could talk about, just kind of for the general pediatrician, and how we can think about these things when we need to and how we would approach diagnosis of it. And then it's also a great board review for residents and med students as well, as I'm in that kind of no time period of residency where I'm starting to panic a little bit about boards because they're actually scheduled now. So this was great board review. Throughout the presentation, you will see these little icons, and they tell you kind of how these diseases can be transmitted. So when you see the hand, it's the direct contact. So that's actually petting an animal, a direct bite from an animal, a scratch from an animal. Indirect contact is when you are around bedding or feces or urine from animals where they've been but they're not currently at. Vectorborne diseases are anything that's transmitted by a different source, so an insect, a tick, mosquito, that kind of stuff. And then foodborne and waterborne are pretty self-explanatory. And so I thought it was very interesting that 68% of United States households have pets. And so a lot of pets will carry these kind of diseases. Okay, so who are at risk? This seems a little bit like common sense, and kind of these are the same people that are at risk for the severe consequences of any infection. Children younger than 5 is a category that we need to be very closely monitoring, and then pregnant women and their fetuses. And then elderly and immunocompromised are also in that category. So I did want to say that we are kind of focusing here on direct animal contact, indirect animal contact, and then contaminating water and food. So vector-borne diseases are a very important and a prominent thing that we talk about and we actually do see in clinic. But there are so many out there and there's so much to kind of go over there. We're going to kind of steer away from the vector-borne illnesses today. And that would be an entire grand rounds in and of itself. So here's just a basic chart that is for Virginia specifically. And so it talks about tick-borne and mosquito-borne diseases and kind of how we're seeing the rise in prevalence there, especially in the tick-borne diseases. So CDC has great information about all of these. So we're going to start out with farm and petting zoo animals. So if anybody went to the pumpkin patch last fall and petted the animals, or you're at the apple orchard with the little kitties. So these are some things to be familiar with. So Brucellosis is the first one that we'll talk about. Just some basic info. There is multiple species of Brucella bacteria. We commonly see that they are kind of in cows, sheep, goats, and pigs. So any kind of farm animals and the animals that you would be petting at the petting zoo. Symptoms, so you get it from unpasteurized milk and cheeses is the most common way of getting this. So if you're getting, we have families that do goat's milk formula that they sometimes make on their own. So that would be something to look out for in this group. If Brucellosis was if you're worried about that, and then cheeses that are made from pasteurized products. So symptoms with these infections are very nonspecific: chills, anorexia. You're going to have muscle and joint pain, so very flu-like symptoms. The board question talks about undulant fever, so a fever that kind of comes and goes over a course of a couple of weeks. And then this one does have the ability to spread throughout the body, so it does have a reticular endothelial spread, and it can go to the large organs in the body. So liver, spleen, lymph nodes are all places that it can spread to and cause more of a systemic disease. So this is one that we do need to have a diagnosis of, and we do kind of want to know about it if it is happening. So this one is a reportable disease, and you should be reporting it. It's a local report that you report it to your local health department, and then they kind of take over from there. And then our treatment, we are treating with doxycycline and rifampin. It says that monotherapy is not appropriate here, and that you should do a double therapy for everybody. 6 weeks or longer is the treatment course here. And then with the doxycycline worry in younger children, they are saying if they're less than 8 years of age, you can go ahead and use trimethoprim, doxazole. So some special considerations here is that these this infection does have very high relapse rates, and some people can actually have chronic brucellosis, and osteomyelitis can be associated with that. So that's something that can be a severe consequence that we should be aware of. And then person-to-person infection is extremely rare, but there is that risk of breast milk transmission. So a mom that has these symptoms and you suspect brucellosis, she does need to be treated. And there are conflicting data about should moms still breastfeed with a brucellosis infection or not. There's not very many cases reported of that, but there is a few out there, enough that there is a warning on the CDC website about it. And then there's that very rare risk of tissue transplant or blood transfusion can also cause this. So Q fever is another one that I feel like is more of a board kind of thing that we talk about, but happens not infrequently. So this one you can get from direct and indirect contact with animals. So this is Coxiella bacteria. We see these in goats and sheep and cattle. These are secreted in the infected animal's bodily fluids, so milk, urine. We see these in birth products, so placenta, amniotic fluid of these animals. So veterinarians and farmers are at a higher risk. But kids can get these of petting these animals, playing on the farm, and this just needs a very, very small inoculation dose to cause an infection. This is going to happen. You're going to have symptom onset 2 to 3 weeks after contact with animal. And then about 50% of these are asymptomatic. But the other 50% that do have symptoms is going to be vague flu-like symptoms once again. So getting a good history from the family about where they've been and what animals they've been around is very important. If a pregnant mom is infected with this, it does have the risk of preterm delivery and low birth weight. So that is something that we, I guess, would have contact with in the NICU if this were to be an issue and cause pregnancy issues. So treatment for Q fever is doxycycline for 14 days. If they are unable to tolerate doxycycline, you can do TMP-SMX or a macrolide. So they are saying that if they're less than 8, to go ahead and give it because it's the less than a 21-day course and it shouldn't have any effect on the teeth staining. That is the risk associated with that. Let's see, and then some other considerations here is that it can cause systemic disease. You can have the hepatitis that comes from it. You can have chronic Q fever that happens in less than 5% of the cases, but that is associated with endocarditis. So kids that already have congenital heart disease or have had artificial valves, that this is something that we need to kind of think about with them. About 20% of people that are infected with Q fever do develop a post-Q fever fatigue syndrome, and that can last for 6 months to a year, sometimes even longer with that. You see antiphospholipid syndrome is listed there, so if there's anything going on, then I'm going to have to put my 2 cents worth in there. So antiphospholipid syndrome, I thought this was very interesting, and it was listed in multiple different resources, that if you have antiphospholipid syndrome and you have active antibodies for that, then you have a much higher risk of severe complications with Q fever. So these complications that they just had listed were stroke, hepatitis, endocarditis, thrombosis, meningitis, and endocarditis. When you look into the mechanism of that, they're not completely sure of why that increases your risk of those. It makes sense with the thrombosis that if your antiphospholipid is higher at that point, then that can cause that. But usually you would do the doxycycline 14 days, but in people with the antiphospholipid syndrome or a higher risk for severe disease, then they want you to treat with doxycycline and hydroxychloroquine until they recover. So that can be a 14-day course, or it can be actually a couple of months long course. And so in these patients with the antiphospholipid, you are going to check their levels every other week until they normalize. And it said that could be a couple of weeks to a couple of months would be that. There are reports of vertical transmission, so transplacental, and babies that are born with Q fever. This one is a little bit hard to, the board question here is that they are resistant to heat, drying, and many common disinfectants. So this one can last on surfaces and can be in like dirt and soil that with the heat it just doesn't kill it. So something to be aware of. So Salmonella is a pretty common one. I feel like we see this on the floor pretty frequently. So we talk about the 2 different types of Salmonella that we're aware of, and then so this is going to be the non-typhoidal Salmonella. So basic information here, 1.35 million cases annually from this. Poultry is the primary reservoir here, but you can get it from fruits and veggies. We see it on the news a lot from spinach, just things that aren't washed very well is where we see these. These are also commonly found on amphibians and reptiles. It is secreted in their feces and then it ends up on their body just from their living environments. And there is a seasonality to this, so we see this most commonly in the summer months. So symptoms of Salmonella is vomiting, fever, abdominal cramps, and then excessive diarrhea, plus or minus the blood. So anytime you see blood and diarrhea, then you have the thought that maybe this is more of a bacterial cause, but it doesn't have to be there. Salmonella is usually self-limited, but it does have the potential to cross that intestinal mucosa and cause more invasive disease. So treatment for Salmonella is that generally no antibiotics are needed. These are usually self-limited and go away on their own, but some people do need antibiotics. So if these are severe cases that they are hospitalized for, or if you are already immunocompromised, or you're very, very young, then you should be treated. So kids less than 5 are most susceptible to this, to Salmonella, and there's currently an outbreak among bearded dragons, which are new and upcoming home pets. So there's a trend where people want bearded dragons as pets, and so they are a common carrier. Yeah, it's more like a giant lizard. Yeah. And then increased risk of this as well are people that are on acid-reducing medications. So sometimes the acid in our stomach helps kill off Salmonella, and so if you're already on an acid reducer, then you have more likely of a chance of getting it. So we're going to treat those that are at high risk of severe disease. So these are immunocompromised. These are your sickle cell patients, so all sickle cell patients to be treated. And then those with a chronic IBD. So if you have inflammatory bowel disease, they are recommending that you are treated here. And then there is some controversy about should you treat little kids no matter what. Some people say that you just treat them if they're severe and if they're hospitalized. And then I saw a couple of different articles that were saying less than 1 to 2 years you should treat everybody if they're symptomatic. So first line of treatment would be fluoroquinolones. And this is for severe cases. We don't really like to use fluoroquinolones in kids. And then otherwise you would use a third generation cephalosporin. You can also use the TMP SMX or azithromycin, I feel like is what more commonly used. If they're immunocompetent and you're treating because they have severe disease, it's just a 3 to 14-day course. And then immunosuppressed is at least a 14-day course, but you should be talking to infectious disease at that point. And some of these kids end up on multiple months worth of antibiotics. Studies show that in healthy people, the antibiotic treatment does not shorten the illness time, and that it can prolong the carrier time of these, so the time that you're actually excreting this in your feces. And then obviously you have the antibiotic risk of disturbing your microbiome. So that was kind of a risk versus benefit thing that we need to talk about. And then in children, if you are less than 5 and you're treated with this, get treated with antibiotics, your carriage time can be greater than 1 year that you're excreting salmonella in your feces. So, and that is much higher than the general population. So some people can be chronic excretors, or carriers, but the less than 5 year age group they can carry for a very long time. This is also one that should be reported to your local health department because they do monitor these outbreaks. There is a transplacental transmission risk, but that is also very rare. There is research that shows that breastfeeding has some protective qualities. And then before you treat, you should be checking with your local resistance microbiome things. So, Tularemia. This one is very, very rare, but I did want to include this one because we did have a case on the floor not long ago, which we were all very shocked about, but it was a great learning experience. So this is from bacteria, Brucellosis. I'm not very good at these names, but so rabbits are the primary reservoir. And so you have an incubation period of 3 to 5 days after coming in contact with this bacteria that you start to show symptoms. But it can enter through multiple sites throughout the body. So it can go through the skin, through a scratch or a bite from a rabbit, or an infected animal, and then eyes, mouth, or lungs. So the board question, we think about aerosolized rabbit matter, which I feel like that would be a very low risk of happening, but it apparently does happen more frequently than we think. Symptoms would be flu-like symptoms. If you are bitten or it goes through the skin at an open site of skin, it can develop that painful ulcer at the site of infection. Usually you just see the regional lymphadenitis, and that is what we saw in that case on the floor. She had a pretty impressive lymphadenitis in her groin area. And then it can have the reticular endothelial spread that causes granulomas and caseating necrosis. So with these kids, these definitely need to be treated. And if you don't treat, mortality rates can be as high as 30%, which is pretty high. So we're going to treat with an aminoglycoside. They want us to do streptomycin is the only FDA-approved medication out there. We do use gentamicin and Cipro as well. But those are not technically FDA approved for the treatment. So this is going to be a minimum of a 10-day course. Usually we treat a little bit longer just to make sure. But if you're seeing this, you should be talking to an infectious disease specialist as well. There are no reports of person-to-person transmission in this, so it is from, so you can't like give it to somebody, or the transplacental issue is not there. Hawaii is the only state that this has never been reported in. And then the CDC has this very lovely warning about being careful while you're mowing, that you shouldn't mow over sick or dead animals, which I feel like that might be common sense, and that if you are doing that, we might have bigger issues, but it word for word says that on the CDC website. So please don't mow over sick or dead animals. This one has many transmission rates, so we get it from foodborne, waterborne, direct contact, and then vectorborne. So, all right. So those are the farm animals and kind of petting zoo issues. The next is cats and dogs. So these are going to be more that we are, I feel like, have the more companionship, that are in your homes every single day kind of thing. So Bartonella is the first one. So this one comes from the Bartonella Hensley. We also know this as cat scratch disease, and we associate this most commonly with kittens, but it can be in other animals. So it's cats, it can be dogs as well. So symptoms are going to be your fever, your unilateral tender lymphadenitis, and then you can sometimes have the pustule or papule at the side of the scratch. So usually we see the kid that comes in with the huge lymph node that is tender and has the overlying erythema and has been playing with their new kitten at home. So these are usually self-limited. There is apparently some huge controversy over, do we treat this or do we not treat this? So some places say we don't treat it unless it is like a tender lymph node and it is causing distress. And then up to date says treat all patients. So the people that are treating all patients are saying that there's a risk of dissemination and that your risk of the prolonged sequela and the risk later are not worth it. So to just go ahead and treat. And it's a short course. So we usually treat with azithromycin for 5 days. Otherwise, you can do clarithromycin, rifampin, or TMP-SMX for 7 to 10 days. If you do have disseminated disease, then you would treat with azithromycin and rifampin. And it is a longer course, but it did never give like an exact of how long. Special consideration is that up to 14% will have dissemination. And so that's kind of what they're covering for with the treating everybody, just to kind of prevent that, since it is a little bit of a higher risk. So you can have hepatosplenic involvement, you can have the neuro or ocular disease involvement. And so risk versus benefit is a huge one here with the Bartonella. Leptospirosis. So there's a lot of information about leptospirosis out there, and I feel like that is a very uncommon thing that we see. So Leptospira interrogans is the bacteria most commonly found in rodents and dogs, but it can be found in other small animals. So this is a spirochete, so it's got a pretty little picture there. And it is only excreted in like urine. It's excreted in bodily fluids, but we think about it most commonly in urine. This is also known as swamp fever. So we do think about this with hurricanes and major floods that happen, which I didn't really think about to begin with. So any freestanding water that can be contaminated by animal urine is a source here. So this can also be found in cattle, pigs, horses, and rodents. So this is a very common thing that we do see in farmers and children of farmers who are playing in the water on the farm or the pond. It enters the body through a skin or a mucous membrane. So these places, so infected sources can be rivers or streams, ponds. So anytime that you're dunking your head underwater, that gives it an easy source to kind of get in there. So incubation period of 1 to 4 weeks. This is going to have the same fever, headache, flu-like symptoms, but you do sometimes have the conjunctival suffusion. And then the thing we really worry about here is disseminated disease. So these are usually self-limited, and not everybody needs antimicrobial treatment. And so you kind of have to, once again, kind of determine the risk versus benefit here. But if you do have complications, they are severe. So in mild cases, they usually use doxycycline for 7 days. If you're severe infection or you're hospitalized, they go ahead and move to IV penicillin as the first line of treatment. You can also use ceftriaxone or cefotaxime, and these are going to be for a minimum of 7 days. These can be confused with rickettsial diseases, so if there is any confusion about what you're treating here, you should always go for the doxycycline, because the penicillins and the cephalosporins don't cover that as well. So if you don't know, if you are treating because you think it's leptospirosis, but there is any thought that this could be a rickettsial disease, then go ahead and use the doxycycline. So we talk about the Jarisch-Hertzheimer reaction. So this is a board question that we see. I know if you've ever used Sketchy Medical, they, and I did use that as a source here, they talk about this in detail, and it is a board question that I have seen in our study and stuff for boards. So you can have this reaction in up to 21% of treated infections. So this is when you're killing off spirochetes of any kind. So this could be seen in like syphilis as well. So when you're killing off the spirochetes in the body, it causes this acute inflammatory response, and you can have the fever, rigors, hypotension. They just look very septic all of a sudden, and it's completely due to the killing of the spirochetes. So this reaction can happen in up to 21% of treated cases. It says that it is most common with one of the Australia strains, and that you see it most commonly in people that are treated less than 3 days of symptom onset. But then in the same paragraph, it says that you have a higher risk of severe consequences if you don't treat within 2 days of symptom onset. So it's like if you have increased risk of severe disease if you don't treat within 2 days of symptom onset, but then you have this 21% of people that can have a reaction if you treat too early. So risk versus benefit kind of thing. And then Wells disease is the most severe form. So this is when our liver and kidneys are involved. This causes jaundice, this causes liver failure, this causes bleeding, issues from the liver failure, respiratory distress, and then most of these patients end up on RRT. So for us, and in this area, we see leptospirosis from farms, and we see it in water sports. So this affects campers at camp that are doing water sports, so kayaking, wading, fishing, anything that you're just kind of standing in the water that could be contaminated with urine. And then hurricanes, heavy rain are also common places. This is an easily killed infection, and so just a diluted bleach can kill it. And then be careful if you go to Hawaii, because that's where most of the cases are seen. Not that that would keep me from going to Hawaii, but just be aware of it. That's where most common place it is diagnosed, just because it's a tropical area and water sports are big. So they do make a vaccine against leptospirosis for domesticated animals. So dogs can be vaccinated. The vaccine does not hit all strands. The vaccine has to be updated at least annually. So just be aware if you do it once and done, then that doesn't really protect them. And there are multiple strains out there, and it just covers against 4. So, okay. And Pasteurella is the next one. So Pasteurella can come from direct and indirect contact with bacteria. It is found commonly in the respiratory tract of small animals. It is not pathogenic to them usually. So you can get this from scratches, licks, and bites. And it is very frequent isolate from dog and cat bites. So 50 to 75%, this is going to be the thing that isolates from dog and cat bites. We have seen a huge increase, I feel like, in dog bites recently. Maybe that's just because we've had multiple. I've been on the floor, but I feel like we have had a couple of admissions, and I keep going back to what should you do with a bite wound. So these are going to cause cellulitis within the first 24 hours of infection. you're going to have purulent drainage from the site, plus or minus some lymphadenopathy, and then if it goes too long, then you do have the risk of meningitis and septic arthritis. These are also found in hamsters, which is a common animal that bites, apparently. And then horses and pigs can also carry this. So the main thing for our kids is just kind of educating families of watching small children at all times around animals, even if it's the family dog that's been there and is loving. Sometimes toddlers don't really understand how to be around animals, and that can cause them to kind of snap and bite. Kissing animals is one of the most common ways that this is transmitted, so don't kiss your animal and don't share your food with your animal. So using the same eating utensil is common. Giving your dog a bite of the popsicle and then putting the popsicle back in your mouth is also common. So I feel like this is easier said than done with toddlers, but don't let the cute family dog lick the baby's face, the brand new newborn's face, please. So we're going to treat this with amoxicillin and clavulanic acid, and that really goes for most animal-associated wounds. So this is going to be a 7 to 14 day course. If you have a moderate infection or it kind of requires more in-depth debridement of the area, you can switch to ampicillin and sulbactam. And then if we're severe infections or in that septic arthritis or meningitis standpoint, then you're going to switch to the piperacillin, tazobactam plus metronidazole. So special considerations are this is a common cause of osteomyelitis and necrotizing fasciitis. This does have the potential with disseminated infection that you can have the transplacental transmission as well. All right, so I feel like this wound care is something that we have had to look up multiple times recently. And these kids that are were having readmits for that they've gone to the emergency department, they had a wound, or they didn't go to the emergency department, and they have this wound from an animal bite, and then it's now infected and there's pus everywhere. So basic preparation of wounds. So the basics: control the bleeding, clean the wound with soap and water, and the antiseptic solution if you have it. Then what is very important with these animal bites is local anesthesia and copious irrigation of the entire wound. So in kids, especially facial lacerations, they can have the granulation tissue that develops pretty quickly. So the wound starts to close even before you can get to the emergency room, within a couple of hours of the injury. And so that actually needs to be opened and everything irrigated. You're obviously going to remove the visible debris in the area. And then that's when just kind of that examine, when you examine at that point, you kind of decide, are you going to close it? Are you going to leave it open? Are you going to treat? So those are kind of things to think about. And more of a general outpatient. Where I'm going is more of a rural area. We don't really have a pediatric ED that's kind of right there, or people that really feel comfortable doing the pediatric. So this is something that I feel like I could be doing in clinic. So do you close the wound? So your choices are to primarily close the wound. So close it, you clean it and close it. You can leave it open to secondary intention and have it close kind of on its own. Or you can leave it open today, have them come back in 48-ish hours, and then close it later. If you wait, sometimes there is that cosmetic portion that may cause more scarring. But then you have the risk of it causing infection and you having to open it back up anyways. So never close a puncture wound. Cat bites are a lot more higher risk of becoming infected for whatever reason. And so cat bites, just kind of think about if you can leave it open, do. So don't close the puncture wounds. Don't, if it looks infected or already has some kind of surrounding erythema, just kind of think about it a little bit more. But it is reasonable to close some simple laceration of dog bites on the face for the cosmetic reason, and then trunk, arms, or legs is okay. Just know that that needs a wound checkup in a day or two. They were very specific to say do not close these with adhesive glue at all. That if you're going to close these, it needs to be with sutures. They should be non-dissolvable, and not to use subcutaneous suturing. So if you're going to close it, it needs an antibiotic. And then obviously if you have any concerns about the location or the complexity of the wound, consider a surgical consult, plus or minus, plastics. When you're doing bite wounds, think about, do they need a rabies vaccine? Do we know this animal that bit them? Do we know if they're vaccinated? Or a tetanus shot? Make sure it's up to date. So things that increase risk of infection in animal bites would be if the hand or foot is involved. So these are the most common places where osteomyelitis is going to occur. We talked about the puncture wounds. The cat bites are more likely to become infected. And then delayed presentation. So if they're delayed on presentation, so if it's greater than 24 hours on the face or greater than 12 hours anywhere else, kind of maybe don't close it as readily as you would something that just happened. All right, so rabies and the beloved movie that makes everybody cry. So this one is not common. This one is very uncommon, but I feel like, especially when we're in the emergency room rotating, that we do see kids that are coming in for rabies vaccines from previous bites. So this has come from a rhabdovirus, RNA virus. Bats are the most common source in North America, but squirrels, skunks, foxes, and raccoons are also common carriers. Worldwide, it is most common that dogs transmit rabies. We don't really usually see that here because we don't have very many, feral dogs running around like other countries do. But dog bites are the most common cause worldwide of rabies deaths. So symptoms, you're going to have tingling and burning pain, muscle spasms, and then that can progress to the hypersecretion of the salivary glands, the spasm of the throat muscles that can cause the drooling and the foaming that we think of, dysphagia, fever, and then encephalitis, ascending paralysis, coma, and death. So scary stuff. But the mechanism of which rabies kind of makes it to the CNS is very interesting. So it has an incubation period of weeks to months, and that time period is determined how close to the CNS that the actual inoculation area. So if you're bit, I don't know, in your chest area, it's going to happen quicker than if you're bit on your big toe. So the retrograde travel, it travels on the peripheral nerves to the CNS, and it can travel at a rate they think is 50 to 100 millimeters per day. And it is a little bit of person dependent of how quickly it travels. But the thing with rabies is if you see symptoms, it's usually too late to do anything about it. So prompt wound care is very important in these people. We should give an antidote prior to any onset of symptoms. So if there's any question about whether the animal could have rabies or not, go ahead and treat. And then this uses passive and active immunity. So the only way to kind of confirm these, and this is more of a board prep kind of thing, is that confirmation of rabies is when you see the Negri bodies. And these are found in neurons. So these neurons are found in the pyramidal cells of the hippocampus and the Purkinje cells of the cerebellum. And there is a med study question out there that asks this, so beware. But that is really the only confirmatory thing, and these are usually completed at autopsy. Hawaii is rabies-free, so just keep that on your list of places you think about moving. There's a pro, no rabies in Hawaii. We gotta watch out for the leptospirosis. So, yeah, risk versus benefit. Okay, this one looks a little weird when it's blown up. But so we talk about post-exposure prophylaxis for rabies. So you're going to use a combination of wound care. So prompt wound care is shown to decrease drastically in infection and just kind of cleaning out the area to hopefully prevent any spread. You're also going to give the human rabies immunoglobulin at the time that this happens or as close to it as you can, and then they should receive the rabies vaccine series. These are recommended for all bite and non-bite exposures, so rabies can be transmitted in saliva as well, so if you have a sore on your hand, somehow you get bat saliva on you, then that would be a non-bite exposure. So, make sure you're cleaning all wounds with soap and water, and then your virucidal agent. And then you're going to give the H-rig or the human rabies immunoglobulin should be given to previously unvaccinated patients. You give it on day 0, so at the time of presentation, but it can be given up to day 7 after the bite or wound. You're going to give this in multiple injections. You're going to kind of try to infiltrate around the wound into any wounds that you can see. But if you don't have a wound present and you think that it was more of like a saliva contact, or then you're going to give it, just the only recommendation is to give it distantly from the vaccine site. So given the vaccine at the site of the immunoglobulin can actually kind of counterbalance each other, and so that you don't have as good of a vaccine response there if you give them at the same site. So the vaccine is a 4-dose series. You're going to give it on days 0, 3, 7, and 14. These are intramuscular injections, and in kids you're going to give it in the deltoid or the thigh. Pediatric vaccine dose is the exact same as the adult dose. So I feel like this was a good review for that. And then our last one that we'll talk about is toxoplasmosis. Very rare, but I feel like we have seen this in the NICU. So it comes from Toxoplasma gondii. It can be from foodborne, waterborne, or indirect contact with animals. This is an intracellular protozoan, and it's thought that 30% of the world's population actually carries toxoplasmosis. So we get this from raw or undercooked meat that contains the actual tissue cyst, and then oocytes in contaminated water, soil, or feces, which sounds really gross. So this is a leading cause of death attributed to foodborne illnesses in the United States, which seems pretty surprising. And it's thought that in the United States, people greater than 6 years old, about 11% are infected. So more prevalent worldwide, but still there. So how this usually happens is that we associate this with cats. So cats eat infected rodents, so then they're infected, and then they secrete the oocyst in their poop for 1 to 3 weeks. And then the human comes in contact with that stool, and they, don't wash their hands appropriately, or somehow comes and somehow ingests that, and then they're infected. So symptoms for the immunocompetent person, you're usually asymptomatic. It can cause a mild flu-like symptoms up to weeks after, but for the majority of people, you really don't see anything. Disseminated disease, the board question is ring-enhancing lesions on imaging with patients that you're kind of working up for encephalitis. So treatment, usually self-limited, like we talked about. You treat if it's severe, or you treat if they have prolonged symptoms. You should treat all cases of congenital infections, and then you should treat anybody who is immunocompromised with a CD4 count less than 100 or positive antibodies. If their CD4 count is less than 100, like in your HIV patients, you go ahead and prophylactically treat them with TMP-SMX always. So we think about this in the pediatric population as congenital torch infection. These can be detrimental to fetuses, and we do see this occasionally. So in pregnant women or women that are infected during pregnancy, this can have transplacental transmission. This is why we ask pregnant women to have somebody else change the kitty litter because of the oocyst in the cat feces. This is sometimes hard to differentiate from CNS lymphoma, so it is very important that you do differentiate this if you have any question at all. This does need an actual brain tissue biopsy for confirmatory testing. So Torches infection, we think about the triad of chorioretinitis, hydrocephalus, and intracranial calcifications. So these kids can have seizures, be developmentally delayed, and deafness is also a common symptom of these. So in congenital toxoplasmosis, treatment recommendations. So if mom is prenatally diagnosed, you're going to treat postnatally regardless of whether mom was treated or not in pregnancy. If you have a symptomatic infection in an infant, so if they have the hydrocephalus, if you have active chorioretinitis, then you're going to treat if you have the following, one of the following. So if you have a diagnosis that is confirmed with serology or PCR, you're going to treat. If mom has a recent documented infection, then it says that you need to go ahead and get confirmatory testing with PCR, and you're going to need mom and baby serum as well as baby CSF that will be sent. If confirmatory test is not available, then you need to rule out other alternatives, but you should be treating this even with just the presumption that they have it. So other etiologies that we think about that kind of present similar to this is CMV and Zika were the two most common that we're talking about. So if baby's initial serology results are equivocal, go ahead and start treatment while the definitive test is pending, because these tests can take months to come back. And then if the final result is negative, then you need to go back and figure out what really is going on. So you need to kind of go back and start over of what are the alternative etiologies there. If you have a baby that you suspect has it but is asymptomatic and you don't have a confirmed test, go ahead and treat. So when in doubt, treat. And then definitive testing can take months to come back. So the treatment here, we're going to treat because the risk of long-term sequelae is so high and is so detrimental. It does say that deferring treatment in an asymptomatic infant is reasonable, but I feel like nobody's going to do that and take on that risk. So you're going to treat with sulfadiazine, and you're going to treat with pyrimethamine, and then the pyrimethamine is a folic acid antagonist. So you're going to go ahead and it can cause the bone marrow suppression, severe bone marrow suppression. So then you're going to go ahead and give them folinic acid as well. And that acts as a rescue medication and is an antidote to mitigate those risk factors there. So we do use folinic acid in our chemo patients very frequently, especially with high-dose methotrexate as the rescue medicine there. Plus or minus glucocorticoids. So they do recommend glucocorticoids if there's any kind of eye involvement. Or if your CSF protein is greater than 1 gram per deciliter, you would also treat with glucocorticoids until that comes back down to a normal range. These treatments are going to be for at least a year. Sometimes we extend these for 2 years, and they have to be weight adjusted pretty frequently. So if in the first 3-ish months of life, they want you to weight dose adjust every week. And then you're going to obviously watch very closely for any kind of suppression, bone marrow suppression. So you're going to do very frequent CBCs starting out twice weekly, and then you're going to do it every week. And then you can eventually kind of space those the 2 to 3 times per month. So information for patients and their families. So hand washing is the most important thing here. Hand washing with clean water is very important. And then alcohol-based disinfectants if you don't have any running water until you can get to running water and use soap and water. Bug spray is very important, especially for the vector-borne ones that we didn't really talk about today, but make sure it's an EPA registered repellent, and tell the mom that is rubbing her essential oils all over her kid for her bug repellent that works, but it doesn't kind of protect us against everything. So maybe use it in conjunction. So wearing gloves when handling dead animals, proper food handling and preparation, And CDC gives a very direct warning about avoiding eating food that rodents have had access to, which I feel like is common sense again, but so only drink water that's been properly treated. Don't be drinking water out of the streams. Make sure it is boiled prior. If you do need to drink that water, keeping your pets up to date on vaccines. Not all animals should be family pets. So just kind of thinking, just because we can doesn't mean we should keep this animal as a pet. And kind of thinking about your family's risk factors of keeping that. So if you have an immunocompromised family, do we need the bearded dragon that can transmit salmonella? And then especially with Easter coming around and the cute little chickies and the bunnies that we use for pictures, making sure that small kids are not snuggling, kissing these chickens and bunnies. And then always monitor your kid, and then enjoy wildlife from a safe distance. Don't be trying to feed the random squirrels or the raccoons. We are professionals at social distancing these days, so enact that with animals as well. This sign I do see throughout Roanoke. This is a Roanoke, Virginia sign. So the poop fairy doesn't exist. Scoop your poop. So being sure that you're not just leaving feces laying around. That's very important. All right, so here's MOC questions. So I'll read real quick. So 16-year-old girl presents for follow-up after completing a 10-day course of amoxicillin clavulant for cervical lymphadenitis. So it's been going on for about 3 weeks. She complains of continued local tenderness and associated fatigue, but no other systemic symptoms. She lives with her mom, dad, grandmother, 3 siblings, 2 dogs, and 2 cats. All have been healthy. She plays mostly with her new kitten that they acquired 2 months ago. On physical exam, you notice a 2 by 3 centimeter tender suppurative lymph node associated with overlying erythema. And this is in the left anterior cervical chain. There's also another node present in the left axilla, but it's non-tender and it doesn't have any fluctuance. So which of the following is the most appropriate next step in the treatment of this patient? If you're online, you can put it in the chat and Miss Jamie will.
We're getting a couple B's.
Perfect. Any ideas here? Agree, disagree? I'm seeing some head shakes. Yeah, so your answer here is going to be that you begin azithromycin. They are trying to hint at Bartonella. She does have some systemic symptoms. She does have tenderness and fluctuance of the area, so you would go ahead and treat her. And this is going to be a 5-day course. So question number 2 is that you have a 12-year-old boy seen in follow-up after beginning treatment with amoxicillin clavulanic acid for axillary lymphadenopathy. His parents state that his pain has worsened and the nodes have enlarged. He's experienced shaking and chills over the last 24 hours. On exam, his temperature is 103.2, and he has an irregular erythematous painful ulceration noted on the left forearm associated with several fluctuant clusters of left axillary nodes. He also has hepatosplenomegaly. So which of the following is consistent with this infection? So what has he been playing with? Do what?
Rabbit.
Yep. Perfect. Yeah, so this is rabbit. So they're hitting at tularemia again. Here we're going to usually treat with gentamicin or streptomycin for him, especially since he has this. He's got some significant systemic symptoms. All right, and then our last question is that you have a 4-year-old child, previously well, 6-day history of subjective fever, abdominal pain, frequent episodes of watery diarrhea. He is afebrile. He looks fatigued, but no abnormal focal findings are identified. A stool culture is obtained, which is positive for salmonella. What is the most appropriate next step in this patient's treatment? We got B's here.
I got to be B's.
Awesome. All right, so no antimicrobial treatment indicated. So this is going to be an uncomplicated bacterial gastroenteritis. So you should only treat those for who are at high risk of complications. All right, so here's some references. And huge thank you to Dr. Washofsky, who helps me come up with all of this and kind of guided me through. Any questions or comments?